Good morning. This is a presentation from Group 5 on USN, USMC, and Australian deployable medical role capabilities. We are going to talk about current Navy Expeditionary Health Service support capabilities and the operational capabilities and Role 2 Health Service platforms for the U.S. Navy and operational Role 2 Health Service capabilities for USMC and Australian forces. Military medical requirements span the spectrum to include international engagement, global health engagements, and full combat operations. This continuum of capabilities provides a variety of tailorable options to commanders and planners. In this brief, we'll touch on afloat and on ashore capabilities and their augments. Only afloat capabilities beyond organic support with Role 2 and above capabilities will be detailed. This will include alternatives to some of the currently configured platforms. The Forward Deployed Medical Unit, the FDPMU, provides health service support by rapidly assessing, preventing, and controlling health threats in the theater of operations and therefore enhancing organic preventive medicine assets. FDPMU is essential to conducting pre-deployment site surveys and assessments to help inform the deployment planning process. Its capabilities and footprints are identified above. Although it is one of the smallest deployable assets, it's one of the most important for obvious reasons. FDPMU is modular and configurable to the need of the mission. These unit type codes allow for greater visibility at the joint level with the focus to deploy a specific capability of the FDPMU. For example, of the 13-member team, 5 can be deployed to specifically conduct occupational and environmental health site assessments, which are comprehensive, all hazard assessments to identify and document complete or potentially complete exposure pathways that could affect the health of the personnel. USN provides medical care to the Navy and Marine Corps during wartime and other operational contingencies. Its two largest platforms are the hospital ships, of which there are 2, and fleet hospitals, which will identify shore-based platforms. Depicted in the comparison and contrast format are platforms Director of Medical Resources, Plans and Policy, N931, has analyzed as potential alternatives for Navy Medicine's future deployable medical platforms, focusing on the 2015 to 2025 timeframe. Note the Navy hospital ships, TAH, operated by the Military Sea Lift Command, are designed to provide emergency, mobile, flexible, rapidly responsive afloat medical capability to provide acute medical and surgical care for up to 1,000 patients and has the largest capacity. Functioning under the provisions set forth in the Geneva Convention, they have capabilities equivalent to the Connors General Hospital Rule 3. The TAH's secondary mission is to provide full mobile hospital services by designated government agencies, HADR, or limited humanitarian care to these missions worldwide or peacetime military operations. This is primarily what many envision when they think of USN GHE missions. Casualty receiving and treatment ships, LHA and LHDs, will be detailed later on. Note that the LPDs, LSD, and LCCs are normally designated as secondary casualty receiving and treatment ships. Besides the medical capabilities of these platforms, other characteristics such as mobility and accessibility are included to inform the planning process. Configuration of the LPD 17 San Antonio class with the primary mission of amphibious warfare is equipped with 2 general ORs and 2 dental ORs, but no organic surgical team and 24 ward beds as compared to alternative depicted on the right side of this slide. Current LSD docking landing ships used to transport and land Marines. The equipment and supplies, either by embarked landing craft or amphibious vehicles augmented by helicopters, and to support amphibious operations including landings via landing craft, air cushions, lacks both ORs and ICUs, and they have only 8 ward beds and 11 medical personnel compared to the proposed alternative on the left of the slide. As secondarily designated casualty receiving and treatment ships, these alternatives will be game changers. USV is a ship that is now in experimental stages as a troop carrier. Depicted is the U.S. Navy and U.S. Army Joint Experimental HSV with its specifications and potential capacity as a national troop transport vessel with accessibility and medical capability configurations. On the left, the CVN supportive missions include medical support for the crew members aboard, facilitated by a self-sufficient carrier hospital, which is a 2-bed Rule 2 facility. The carrier's medical department also serves as a consultative and primary medevac facility for the other vessels within the carrier strike group. LHAs are capable of receiving casualties from helicopter and are designed to function as CRTs in amphibious operations but limited to 2 operating rooms. The LHD on the right is the largest and most versatile amphibious assault ship. Externally, it resembles an aircraft carrier. The LHD is capable of transporting approximately 1,800 troops along with the helicopters, boats, and amphibious vehicles required for landing them. LHDs are the largest medical capability of any amphibious ship currently in use. The fleet hospitals and expeditionary medical facilities deliver Rule 3 capabilities, so they will not be detailed further than is depicted for general planning purposes. Fluid medical assets. Fleet surgical teams, FST, are medical assets owned by the Atlantic and Pacific fleets non-BSO 18. FSTs augment an established medical department aboard a casualty receiving and treatment ship, providing medical and surgical support, expanded lab and blood bank services, intensive care and ward care, and limited en route care capability. Their mission is to provide medical and surgical support Level 2 HSS capabilities to designated operating forces of the Atlantic and Pacific fleets during fleet and Marine Force exercises and routine deployment of CAF and ASG. ERSS, which is the Expeditionary Resuscitative Surgical System, is a component to the Global Naval Expeditionary Care System for forward resuscitative surgery, a highly responsive, mobile, and flexible system of trained personnel and equipment to provide tailored, mission-specific medical capability close to the point of injury that supports the range of military operations afloat. Focus is on having immediate life and limb-saving surgery, trauma care, medical evacuations, and en route care at or near combat operations. This will be an expansion of the Shipboard Surgical Support Initiative and existing FST, able to support split RG, Special Operations sector. It's made up of 3 interacting components based on the Fleet Surgical Team with Health Service Augmentation Program personnel. One of them is the Expeditionary Surgical Team, EST, which provides forward initial emergency damage control surgery capable of functioning from a small platform or from a shore-based position. The team consists of 1 general surgeon, 1 anesthesia provider, 1 critical care nurse, and 2 OR techs. It is set up within 45 minutes, up to 5 damage control cases, and holds patients for up to 2 to 4 hours. The second is the Expeditionary Trauma Team, ETT. It's capable of functioning from a small afloat and ashore platform to provide initial services, initial emergency life and limb saving actions. The team consists of 1 emergency physician and 1 independent duty callman. The third is an en route care team, ERCT, which safely transports and provides critical required medical care of patients at risk of clinical status changes during movement between capabilities in the continuum of care, capable of medically managing 2 stabilized casualties for 2-hour transits. The team consists of one flight corpsman, ETT, a critical care nurse, can move with patients to provide continuity. Peacetime Medical Department of the Casualty Receiving and Treatment Ships, CRTS, even with a fleet surgical team, is inadequate to fulfill the wartime medical mission of the LHA or LHD. Therefore, 83 additional health services augmentation personnel are assigned to the CRTS upon request and approval of the OPNAV N931 and VMED. The specific billets of the N+1 wartime managed augmentation team are under continuing evaluation, but presently located on platforms depicted in the chart and consist of the specific core depicted to the right of the slide. Mission of the M+1, required operational capability ROC, and the projected operational environment POE for the LHA and LHD provides surgical capabilities of 4 ORs, 15 ICU recovery beds, 45 ward holding beds, and a blood bank capacity of 500 plus frozen blood units, FFP, and a walk-in blood bank. The N+1 mission is to meet the ROC or POE requirement of the medical department. Additionally, these assets may be used for humanitarian and disaster relief missions. Marine Corps Operational Role 2 Health Service Capabilities. A large percentage of the Marine Corps medical assets are Med Augmentation Programs, MAP, Health Service Augmentation Program, HSAP, personnel assigned during deployments who usually work in military training facilities when units are in garrison. While in the ground, air, and logistics combat elements all have some form of medical capabilities for organic support, will continue to focus only on the Role 2 capabilities of the Forward Resuscitative Surgical System, the FRSS, and the surgical companies. Deployable medical capabilities. The U.S. Navy and Marine Corps form a team in all ranges of military operations. Therefore, the Bureau of Medicine and Surgery, the BUMED, is funded and equipped to provide forces for health service support, HSS. The HSS, aided by technology, innovation, and logistics, is the employment of medical forces in support of the warfighter. HSS provides essential theater care for wounds, disease, and non-battle injuries, and case evac and medevac of casualties to MTFs in CONUS for definitive care without sacrificing quality of care. Health service support deploys small, mobile, and task-organized capabilities to provide care throughout the continuum of the healthcare. The Marine Corps HSS's continuum of healthcare capabilities, forces commanders and unit leaders. They have HSS staff that plan from the tactical level through the strategic level of the war. The medical battalion holds the main asset of the MEF's preventative medicine, which is deployed to component elements and support units. The first responder capability is organic to every unit and elements of the Marine Force, starting with the self-body aid to medical officers of the unit known as Role 1. The forward resuscitative capability, also known as Role 2, is the main capability of the medical battalion, which also starts from the 8 stations of the individual units and continues with the shock trauma platoon, STP, and the forward resuscitative surgical system, FRSS. Theater hospitalization capabilities is embedded in the resource available to the medical battalion to hold patients who could recover and return to fight within a short time without getting out of the theater for care. The Marine Forces is furnished with expeditionary medical facility units, EMF and EMU, which include hospital ships and fleet hospitals to provide Role 3. The EMFs are medically and surgically intensive and deployable in a variety of operational scenarios. The en route care system transports patients through the continuum of care. The USN and USMC teams are organized to have Role 1 as an integral part of the tactical force. Role 1 care is provided by both medical and non-medical personnel who have been trained in all service member tactical combat casualty care, also called TCCCASM, also known as Combat lifesaver. The hospital corpsmen and medical officers or providers work out of 8 stations, and the number of corpsmen, HM, is high. The number of HM assigned depends on the numerical strength of the units. In most cases, the providers are independent duty corpsmen, IDC, physician assistants, nurse practitioners, or physicians. Team in Role 1 trained the unit's Marines and sailors in tactical combat casualty care Tier 1 and 2. The training increased the unit's medical readiness and capabilities, enabling the force to provide self and body aid care for one another before the assigned medical team arrived. The aid station is equipped to provide medical care to the sick and injured with minimal surgical procedure capabilities. Role 1 is assigned Block 635, which is the battalion aid station equipment, Block 636, the battalion aid station consumables, Block 699, the sick call block, and Ambulance 997. The medical officer may request other blocks as necessary to accomplish a mission. The field medical technician assigned to the Role 1 is allocated the Core Assault Pack to provide tactical field care to casualties under fire. Battalion. Within the Marine Expeditionary Force, the Medical Battalion is the only Role 2 capability health service force organic to the Logistic Group MLG, which may be divided into elements that provide internal support to the MLG and external support to Marine Air Ground Task Force elements outside the MLG. The Medical Battalion is made up of a headquarter and service HNS company and its subordinate surgical companies. Within the Medical Battalion is also a preventative medicine unit composed of an environmental health officer, entomologist, and preventive medicine technicians. The preventive medicine unit is a significant force enabler capable of providing a full scope of preventive medicine and occupational and environmental health site assessment activities for the purpose of ensuring a healthy deployable force. The combat stress platoon and chaplain section are also included in the H&S company. Medical battalion's tasks include the following: to provide Role 2 care, to include initial resuscitative care, restorative surgery, and temporary holding of casualties to the MEF. They provide medical regulating services to MEF. They provide preventive medicine support to MEF. They assist in the collection, analysis, and dissemination of medical intelligence. They provide the medical elements for the establishment of casualty decontamination and treatment stations, and they provide the medical support for the management of mass casualties and combat stress casualties. The company is designed to deploy with direct support Combat Logistics Battalion, CLB, in support of a regimental combat team. The CLB provides the surgical company with electrical power, communications, transportation, and services and other for the SC to provide health service support to the regimental combat team. The SC provides forward resuscitative surgical systems, the FRSS, shock trauma platoons, STP, medical treatment, and temporary holdings of casualties from supported forces. The surgical company is a major link in the chain of evacuation. When practical, it can be located in close proximity to an airfield that is capable of case evac by rotary or fixed-wing aircraft. There are 3 surgical companies in each of the 3 medical battalions, 9 total. The setup takes 12 to 24 hours. Resuscitative Surgical System, FRSS. This is a highly mobile, rapidly deployable trauma surgical unit that will provide emergency surgical interventions required to stabilize casualties who might otherwise die or lose limbs before reaching treatment. The FRSS supports early introduction into the operating area, rapid movement, erection, deployment, and redeployment in forward areas. It is the initial surgical capability ashore in the traditional amphibious assault, or it may be the only surgical capability ashore. This asset consists of 2 general surgeons, 1 anesthesiologist, 1 critical care RN, 1 independent duty corpsman, and 3 OR techs, Why did I have to do that? Forward Resuscitative Surgical System, FRSS. This is a highly mobile, rapidly deployable trauma surgical unit that will provide emergency surgical interventions required to stabilize casualties who might otherwise die or lose limbs before reaching treatment. The FRSS supports early introduction into the operating area, rapid movement, erection, deployment, and redeployment in forward areas. It is the initial surgical capability ashore in a traditional amphibious assault, or it may be the only surgical capability ashore. This asset consists of 2 general surgeons, 1 anesthesiologist, 1 critical care RN, 1 independent duty corpsman, and 3 OR techs. Role 2 provides advanced trauma management and emergency medical treatment, including continuation of resuscitation started in Role 1 to prevent loss of life, limb, and eyesight. Role 2 care has the capability to provide packed red blood cells, limited X-ray, laboratory, dental support, combat and operational stress control, PVT med, and Role 2 veterinary medical and resuscitative surgical support. Role 2 has a limited hold capability, no bed capacity. Role 2 is classified into Role 2 Light Maneuver 2LM and Role 2E Enhanced 2E. Role 2LM is a light, highly mobile medical unit designed to support land maneuver formations, normally brigade level. The Role 2LM medical unit is able to conduct advanced resuscitation procedures up to damage control surgery. It would evacuate its post-surgical cases to Role 3 or 2E for stabilization and possible primary surgery before evacuation to Role 4. 2E provides basic secondary health care built around primary surgery, intensive care unit, and ward beds. 2E MTF is able to stabilize post-surgical cases for evacuation to Role 4 without the requirement to first route them to a higher Role 3 facility. Role 2 care should have the minimum capability for packed red blood cells. Additional blood product support to include frozen plasma, cryoprecipitate, and platelets should be considered based on desired level of trauma management and availability of necessary supporting equipment and supplies. Operational Role 2 Health Services capabilities. Headquarters HQ2 Brigade and its units are organizationally structured to achieve a raise, train, sustain effect that is capable of generating task-organized, deployable health capabilities to support diverse mission requirements. 2BDE has personnel posted to over 30 locations throughout Australia. It is an integrated brigade, fully utilizing the total workforce system to generate capability. In garrison, units of 2BDE are aligned to establish habitual relationships with co-located dependencies in order to support each other's training. 2BDE's contribution to Role 2 is through generation of Role 2 Forward, Role 2 Basic, and Role 2 Enhanced capabilities. The Role 2 Basic is larger and more capable than Role 2 Forward. In this regard, the generation of 2BDE Role 2 capabilities aligns to NATO Allied Joint Publications 4.10, Aligned Joint Doctrine for Medical Support. 2BDE's contribution to evacuation is through surface evacuation teams and aeromedical evacuation teams. 2BDE has limited organic evacuation platforms and will often rely on platforms from supported force elements to achieve an evacuation effect. 2BDE has no aeromedical evacuation platforms. We'll focus on the Role 2 capabilities of specific teams and that of the 2nd and 3rd Health Battalions. Australian Role 2 capabilities routinely include emergency physician-led resuscitation, surgical capabilities, post-surgery intensive care and ward services, and rely on integrated teams of specialists. Surgical teams treatment is often limited to damage control, a clearly defined list of interventions aimed at saving life, limb, and eyesight. The damage control principle is used to guide the structure, process, and norms of the Role 2 facilities and determines and binds the requirements for pharmacy, medical imaging, laboratory, blood, and other services in the medical treatment facilities. Ward and holding capabilities will be influenced by the theater evacuation policies and availability of tactical and strategic evacuation. The role of 2HB is to provide up to Role 2 Enhanced R2E combat and allied health capabilities in support of the integrated force. ACOI First Surge is located in Brisbane and provides up to a deployable R2E. BCOI 11CHC is located in Brisbane and provides up to R1 integral and closed health capabilities. CCOI OSC is located in Brisbane and provides logistics and allied health capabilities. DCOI is located across NSW and ACT and provides up to R1 integral, closed, and allied health capabilities in addition to managing reinforcing elements. 3HB is to provide up to Role 2 enhanced combat and allied health capabilities in support of the integrated force. 3HB consists of HQ element and 4 companies. ACOI is located in Adelaide, structured to provide up to deployable R2. BCOI is located in Adelaide and provides up to R1 integral and closed health capabilities. CCOI is located in Adelaide and provides logistic evacuation and allied health capabilities. DCOI is located in Melbourne and Hobart and provides up to R1 integral, closed, and allied health capabilities in addition to managing reinforcing elements. Forward Team R2F. The R2F is a trauma-focused capability that is highly mobile and deployable into remote, austere, and insecure tactical environments, enabling forward projected DCR and DCS to control bleeding. The R2F, the Role 2 Forward Team. The R2F is a trauma-focused capability that is highly mobile and deployable into remote, austere, or insecure tactical environments, enabling forward projected DCR and DCS to control bleeding, maintain circulation, restore perfusion, and preserve life, limb, and function. R2F capabilities may be used as part of entry operations, surge support, or where medevac to R2E or R3 is not achievable within clinical timelines. They may also be deployed to augment or to enhance other medical capabilities in theater. R2F have limited post-surgical holding capacity of 1 bed. If not enhancing or augmenting other medical support capabilities, which include patient holding and post-operative care, R2F rely on immediate medical evacuation and resupply after surgical treatment. R2F is not definitive care facility. The Role to Basic Team R2B. The R2B provides damage control, resuscitation and surgery, short-term post-operative critical care, and limited patient holding. Post-surgical holding is a major point of difference from R2F. The R2B may deploy ahead of anticipated larger capability or as the highest level of clinical capability within a specific area of operation. Due to the limited holding, R2B requires clear word lines of evacuation in order to maintain capacity. Enhanced Light Team R2E. R2E is the highest level of care generated by 2BDE. It is scalable based on mission requirements. R2E provides force preservation surgery, damage control surgery, intensive care, and ward beds. It contains integral pharmacy and logistics support and can be augmented by various allied health elements. R2E requires extended lift, communications, and engineering support, generally from the FSG. They require 48 to 96 hours to reach fully operational capability. The mission profile for R2E is static. It can deploy under shelters or occupy hard standing opportune infrastructure. While it can be redeployed, this is a significant planning and operational consideration. Scalability is a fundamental principle of the R2E. The scalable characteristics of the R2E exist both within units and across 2BDE. Broadly, if a single surgical coil from 2 HP or 3 HP generates a R2E effect, it is considered R2E light and is commanded by an O4. If both surgical companies combine, then R2E heavy is generated and is commanded by O5. Both the R2E light and R2E heavy can scale within themselves based on mission requirements to include allied health and other enablers. Shown here is an alternate role to enhance R2 light build examples. On the slide is the R2E heavy team, and you can look at that the difference between that and the R2E light team. Slide is build examples of the R2 heavy build. These are designed to trade skill for maneuverability. In this regard, a clear correlation exists between size, the maneuverability, and capability. This table outlines the broad comparison between the Role 2 elements. Allied health enablers are modular and can augment any Role 2 if the mission requires. Those identified are available options for each Role 2 capability based on likely mission profiles, operating environment, and mobility. Here's an overview of the deployment planning data for each of the Role 2 capabilities, the R2F, R2B, R2E light, and R2E heavy. So we can see the table clearly gives the differences between these four. What was interesting to note during the development of this brief is that doctrinally, a common function of both the Australian Role 1 and Role 2 is to provide medical officer-led resuscitation. The stick point is when it comes to damage control surgery, which is the greatest discrepancy between NATO definition and US Army doctrine. As per the NATO Standard Allied Joint Doctrine for Medical Support, the Role 2 encompasses a set of military healthcare capabilities which enhances the resuscitative spectrum of the Role 1 by capabilities essential to preserve life, limb, and function and stabilize the patient's condition for further transport and treatment with all three iterations, forward, basic, and enhanced, detecting a surgical capability. In direct contradiction to this, as outlined in the US doctrine, the medical company, Role 2, this interpretation is openly rejected, professing that surgical capability is not mandatory at this role. At its core, the Role 2 purely duplicates the Role 1 and expands services available by adding dental, laboratory, x-ray, and patient holding capabilities. And we concluded by saying medical interoperability in the deployed environment is vital to the health capability of allied nations. What proves pivotal in enacting this function is the ability of said nations to read from a common playbook. Incorrect interpretations of doctrinal definitions can hinder the understanding of throughput capacity, especially in the health planning phase. A greater appreciation of the discrepancies of allied nations' doctrinal definitions is required, and often the incorrect promulgation and interpretation of these definitions is what generates confusion. Thank you.